Of our entire team, I want to welcome all of you guys. We're excited. This is our second annual nursing symposium at Innovations, and we're just excited to have you guys here. How many of you are not from Baptist Health? Wow, awesome. Well, welcome. We're excited to have you. So I hope today it's engaging for you. I hope it's energizing for you. We do a lot of hard work in this field, and I know it's tough some days. So I do want to make a few announcements. If there should be some tickets in your packets, we're holding a reception at the end of today, so hang around and we'll all have time to sort of mingle and talk and network. And then if you have CE or CME forms, make sure you turn those in. We cannot give you credit for these sessions if you do not turn in the forms. They're very, very strict on that. So make sure you've signed in. You'll have to sign in every day, just a reminder. Make sure you sign in every day and you fill out the forms for every day to get credit. And then last but not least, if you guys need any assistance, if you have any questions about anything, parking or whatever, see Abby or Brittany or Brian Sable, the people that were kind of helping you check in, and they'll get you squared away. All right, so we'll go ahead and get started. So it's not often that any of us get to participate in things that are really groundbreaking, right? But in this field right now, that's what we're all doing. Things have changed a lot in the last 10 years. And specifically, as we celebrate the 5th anniversary of this program, I just wanted to take a minute to thank everybody, whether you work at Baptist, whether you work at hospitals that are not part of Baptist. We do a lot of really hard work. So whether you're an OR nurse, an ED nurse, an ICU nurse, a PACU nurse, a nurse on the medical floors or the med-surg floors, a pharmacist, a rehab professional, a physician, an IR tech, a CT tech, an MRI tech. If you work in a rehab that's sort of in the post-acute space or even home health, we're glad you're here. And you guys all have a tremendous impact on the lives of these patients. And so collectively, the things that we do save lives and they rewrite patient stories. And I say that we rewrite because 10 years ago, the stuff that we're doing, a lot of it wasn't here, or it was here, but only in its infancy. And so we're really sort of at the forefront of some groundbreaking technology and science. So what I want to say thank you for, though, is the long, hard days that you guys all put in. So things get tough. Your day doesn't always go as planned. Sometimes you're missing supplies. Sometimes you're dealing with families and patients that can be kind of difficult. Sometimes it's not the families or the patients, but maybe somebody else. You might be missing orders. You might have to take 4 or 5 trips to CT or MRI or to the OR. Your day gets long. It's exhausting physically and emotionally. But most of us came into this profession so that we could make a big difference in patient lives and outcomes. But I think sometimes the difficulties that we face make us sort of question whether it's the right fit for us, because it gets hard. But I want to talk to you about why we do that. So in a few minutes, we're going to see an example of why we do that. And so I'm really excited about this. It's the first time we've done it. But when I started, like I said, dabbling in neuro about 15 years ago, there really wasn't much we could do for stroke patients. And even aneurysm treatment wasn't quite the same as it is today. But why has all of this changed so much? And it's because of the persistence and the perseverance of everybody in this field. It's physicians, it's nursing, administrators, it's everybody. So the outcomes that we're seeing in patients today are pretty incredible, and you're going to get to witness that in just a minute. So like I said, in the minute, you'll get to meet one of our Ys. He's one of the sickest of the sick that we've had in our ICU. And, you know, a lot of us didn't really know what the outcome was going to be, but we persevered, and his family persevered, and he persevered, and he's here with us. And we're going to get to meet him, and then Dr. Savage is going to talk a little bit about aneurysm treatment in this day and age. So again, I want to say thank you guys. Thanks for coming. Thanks for being a part of everything that we do. And I hope you guys enjoy today. And I'm going to bring up Dr. Nima, and he's going to kind of introduce our speakers, and we'll go from there. So thank you guys. Thanks again.
Thank you, Wendy. Thank you, everybody, for being here. I'm very, very excited about this conference. We have great speakers for you. Thank you for the committee for putting this together. I wanted to briefly echo what Wendy said. I had a patient I saw a few days ago. The family were so impressed by what we did for their father that the daughter wants to be our spokesperson, because she said when we got to the emergency room, everybody worked so efficiency, and they were so efficient, and they worked so hard to try to treat my father, from the CT scan to the OR staff to the procedure to the ICU to the floor. So they were very impressed by what we do. Yet we do this every day, and you guys who are really what makes this happen. So I thank you for all your hard work, and you should know that we do have one of the top programs when it comes to cerebrovascular disease, and we're very proud of that. We're very passionate, but again, we couldn't do any of this without you guys. But having said that, again, thank you for being here. I'm supposed to introduce Eric Savageau. Dr. Savageau, I don't think needs much introduction, but he's going to talk to you about aneurysms. Then you have a lot of good speakers about stroke localization, about ischemic stroke, anatomy, and different things. So please enjoy it. And Dr. Savageau knows a lot about a lot of things, aneurysm, strokes. But you should know that I've learned he's really good at hockey. So feel free to talk to him about that later. And hopefully you enjoy his talk. All right, thank you.
Good morning, everyone. It's a pleasure to be here, and I just want to echo that, and I'm going to come back to that during the lecture. But yeah, I'm really grateful. I decided to move here 5 years ago with my family, and it wasn't an easy decision. Again, I love Columbus, Ohio. I love Ohio State. I still love them. I think they have a great football team. But it's been a great decision, and again, all of you make it possible to do what we're doing. And a lot of time you guys are in the shadow of what we're doing, but I could tell you what we're doing is nothing. It's just sometimes, get the glory and all that is the cherry on the sundae. But at the end of the day, what really matters is all of you guys. And I really mean it, and we all mean it, because you make the difference. And we're just fortunate to be part of this team. I have nothing pertinent to this presentation to disclose other than I'm French Canadian, and that's why I have this accent. But recently I got naturalized, so I'm not American. So I think it's my first lecture as an American. Thank you. So this is the team. I point about this, I mention about this, and obviously there's just part of the team. Everyone in the hospital, including the janitorial team and all that. I mean, everyone has an impact. A smile here and there could make a huge difference for the patient, for their family. So again, really, really important. Now, cerebrovascular disease, as Wendy pointed out, the treatment of that, the paradigm has changed quite a bit over the last decade. In fact, since I started training in the 90s versus now, a lot of things we're doing were not even available. There's still two tools, I would say. One is the knife and the microscope, but more and more the endovascular therapy is the main way to treat most of those lesions. If we look at the evolution, it's amazing, because if you look in medicine, for example, if you have appendicitis now, the treatment is not that different than if you would have shown up 50 years ago as far as the technical aspect of it. If we look at endovascular therapy, in 1930, Edgar Moniz was the first one to do an angiogram. So it was the first one to directly stick a needle in the carotid of someone and inject contrast. And interestingly, an initial paper showing that it was feasible, 8 of 10 patients die from stroke or direct complication of the procedure. So obviously 80% morbidity and mortality for an angiogram in 1930 versus where we are now. While an angiogram has barely 1/3 of 1% risk, it's amazing the changes that have happened during this time. If we look in the 1990s, one of the things that has changed quite a bit is the evolution of the coil. So basically what happens, we had a device now that we could put within the brain, within a vessel, and if we're not happy with the positioning, we could pull it back. So we had a way to detach the coil instead of just throwing something in the vessel, hoping for the best. And obviously over the last decade, treatment for thrombectomy and stroke has dramatically evolved. And endovascular therapy, which until the mid-90s, 2000 was mostly towards brain aneurysm, now has completely shifted, and most of the procedure we're doing are regarding stroke. This is a subarachnoid hemorrhage. This is a scan without contrast. So you could see here, all the white here does not belong there. So someone that if has no history of trauma, the most frequent cause is a ruptured brain aneurysm. You could see here, an aneurysm, what it is, a bulging on the artery, and then it bleed. And unfortunately here, the outcome was bad on this patient. You could see all the blood at the undersurface of the brain. Now, this is quite a bad disease. 40% of people will die. It's more frequent in women. There's about 40,000 patients in the United States every year that are going to bleed from a brain aneurysm. People who sustain a brain aneurysm and survive, a lot of time their life is changed forever. Most of them won't go back to work. A lot of them won't get back to the kind of life they had before. A lot of them, and the majority of people who have brain aneurysm are, you know, between 50 and 60 years of age, but any patient could have brain aneurysm, including a children to elderly. What could we do to prevent that? The reality is most of the time brain aneurysm, there's nothing we could do really to prevent that other than smoking. And there's factors that could contribute to increase the risk of brain aneurysm, like increased blood pressure, polycystic kidney disease, fibromuscular dysplasia, and other more rare syndrome. Now, what I'm discussing about here is saccular aneurysm or berry aneurysm. There's other kind of aneurysm that are fusiform aneurysm, and there's other aneurysms that are mycotic aneurysm that come from an infection. Obviously, those kind of aneurysm are a little bit different in the sense that one of the treatment as well for mycotic aneurysm obviously is antibiotherapy to make sure that the infection is treated itself. It runs a little bit in the family. If you have one person that have a berry aneurysm in your family or another person, your risk increased a little bit. Now, how does it show? Does it show like a headache, like a Saturday morning after you had a big Friday evening, you wake up with a bit of headache and all that? Is it concerning? No. Headache for brain aneurysm, people describe the worst headache of their life. It starts all of a sudden. It's like somebody hit them with a baseball bat, no headache, boom, worst headache ever. And a lot of time, depending on the intracranial pressure, people could fall into a coma or have other sign associated with it. So you could see here a large an aneurysm that rupture in the temporal lobe. Now, before the 1990s, the main treatment option was clipping. It was a good option, but you'll see the endovascular therapy has evolved quite a bit, and it's now the main way of treating brain aneurysm. Now, the treatment was simple, finding the aneurysm. You could see here this outpouching there does not belong there, and you just put a clamp at the base there, and then this way there's no more blood going into the aneurysm, and the aneurysm is not at risk of bleeding anymore. We're getting quite good at this to try to minimize our trauma to the brain, but every time we open the brain, there's still things that could happen. We're developing a way to cut the bone of the orbit, so instead of pulling on the brain, we go under the brain to limit the trauma of that. Now, this is a middle cerebral artery aneurysm, and you could see we're quite delicate, at least I like to think. You know, we're not pulling on the brain and all that, and we're looking to find the aneurysm to put a clip on it. But every time that you do brain surgery, sometimes, you know, people will come and say, you know, people look like they're going good, but they're a bit elderly. And the family will say, you know what, grandpa's doing good, but his memory is a little bit different. So even if the surgery went as well as you can, there's sometimes something a little bit different. And it's really frustrating for us because there's really nothing at surgery you wish would have happened differently. There's nothing different. It's just sometimes we don't belong there. And this is an interesting book from Frank Vertozik, who was a resident in Pittsburgh in neurosurgery, who, in fact, after his training, decided that neurosurgery was not for him and decided to become a psychiatrist. But in his book, he put few rules, and the rule number one is really good, is you ain't never the same when the air hits your brain. Yes, the good Lord rigged that sucker and pretty good and for a reason. We're not supposed to play with it. The brain is sort of like a 66 Cadillac. You had to drop the engine in that thing just to change all 8 spark plugs. It was built for performance, not for easy servicing. And the same is true for the brain. Again, sometimes things could happen. So that being said, if there's ways that are less invasive, I'm the first one. If somebody's telling me that they're going to crack my skull open versus, you know, puncturing my groin or my wrist, I'm going to sign up for the groin puncture. So there was no doubt, as well as the field was evolving, that there's no doubt that it was there to stay and all that. Now, initially, people would say, you know, coiling, that seems fancy, this technology thing, but this is not gonna work. You know, this is not as definitive. I'm sure it's not helping the patient. There was obviously a lot of doubt about this because clipping had been going on for a long period of time. So the first study, which was comparing both, was called ISAT, and ISAT was looking at patients who could be treated both ways. So there's still a lot of patients who could not be treated both ways, but patients that could be treated both ways, people would flip a coin and they would get either clip or coil. And what it shows is that at 1 year, patients who were treated with coil or endovascular treatment had 23.9% higher chance of being independent. So the outcome was better when people would coil and clip. Now, does it mean we coil everyone? No. We're calling more and more aneurysm. We're treating more and more aneurysm endovascular, and you'll see why, because we have way more tool than we used to. But it still depends on particular situation. Some patient aneurysms still are better tailored for clipping. It depends on how the patient look. It depends of the age of the patient sometimes. It depends of the patient and family consent. Some patient, interestingly enough, have strong opinion versus clipping or coiling. So all that need to be taken into consideration. One thing is sure is that when we look at microsurgical technique, where the progress is really linear. So it's not really disruptive. We're just building, we're getting better. Our instruments are getting a little bit better. We're a bit more careful. Our microscope are getting more powerful. We see better. But if we look at endovascular therapy, it's quite disruptive. It's completely changing the paradigm, changing the way we look at aneurysm and deciding to fix them from inside instead of outside. And obviously, you know, this is just the beginning, and you see the speed that those devices are available. It's dizzying to some extent. So what is a coil? A coil is a loop of platinum. They come in different size and shape, and basically we just go within the aneurysm and we put those loops of platinum within the aneurysm. So this way it put the band-aids within the aneurysm itself, and it prevents the aneurysm from bleeding. Now, this is an example of this. You could see a large basilar aneurysm. Those kind of aneurysm were the first one that we all agree, I would say, as a community, that it was better to treat them endovascularly, because those aneurysms surgically in this location, the morbidity is at least 30%. So it means that you could take someone and you have 30% chance of hurting those patients trying to help them. With coiling, the risk of us hurting patient is probably less than 3%. So obviously, this is quite an advance. So you can see here the aneurysm has been filled with the loops of platinum, and the normal artery fills normally. Now, sometimes the base of the aneurysm is a bit too wide. We could use an adjunct with the balloon. It helps keeping the coil within the aneurysm. You could see it's an example of that here. And sometimes we copy a little bit what was happening in cardiology. We could use a stent. Now, the problem with the stent is that people need to be on aspirin and Plavix. If people had just a rupture aneurysm, you need to put sometime an external ventricular drain or other thing like this. It's not a good idea for those patients to be on aspirin and Plavix, because obviously there's tremendous risk associated with it. So this is something that usually we'll use to treat people that are on rupture, that have aneurysm that are on rupture. However, in some circumstances, you'll see that we don't have any other way to go about this, and we go with the risk of the dual antiplatelets therapy. You could see other adjunct here, a pulse rider, the piconus. Basically, it helps us support at the base of the aneurysm to try to put the coil in there. And something that has changed quite the scenery of brain aneurysm is flow diversion. So the most frequently employed, and until recently, the only FDA approved, was the pipeline. So basically, it's a tight mesh. So the mesh is really, really tight. There's nothing that could go through that. You cannot put coils through that. You cannot put a catheter to that. It's almost like a screen. So if you, just the best analogy for that is that if you throw water to someone, obviously it's going to get wet. If you throw a glass of water through a screen, still water will go through, but it's going to decrease tremendously the speed of the that the water was coming at you. So this thing does the same thing. It decreases the influx of blood within the aneurysm, allow the aneurysm to shrivel, and slowly the wall of the flow diverter is being populated by your own cells. So it kind of remodels the vessel and makes sure that the vessel become lined and does not have this irregularity in the aneurysm. Now, there's two other devices that are not approved, and this is an example of the pipeline. That has not been Photoshop. You could see here, this is the aneurysm. After the flow diverter, a few months later, the aneurysm is completely obliterated. You could see here a large aneurysm that is going in the basal ganglia. So use both here, put some coil, and you could see the flow diverter here, and you could see initially, amazingly, you could see from that, you get to that. So you could see it really remodeled the vessel. Even the neck of the aneurysm, now that it's a dead end, has completely healed, and you could still see flow in the anterior cerebral artery. Another example with another device. And more recently, the web came, which is more an intra-saccular flow diverter. So it's putting a meshing within the aneurysm itself. You could see here an example. The device is put there, and it kind of treats the basilar aneurysm. Now, this is it for the theory. Now I'm going to tell you a story. This is on November 8, 2018. This is a new tendency. That's usually how I meet people online, looking at their CAT scan. Some people go on Tinder and those kind of things. But so we got a call. This is a patient transferred from an outside hospital who has, at this point, you guys should be able to tell me here, subarachnoid hemorrhage. And this is a young patient, a young adult, and his ventricle here, because of the bleed in the plumbing system and so on, has hydrocephalus. So those ventricles are larger than it should be. So basically at this point, we're gathering a little bit more of the story. And this is a patient who has an endocarditis, has been on IV antibiotics, and he woke up that morning with a headache, and quickly it became the worst headache of his life. And then he lost consciousness and had a seizure. This patient arrived, we placed an external ventricular drain, and then we did an angiogram. Now, if you look at this basilar artery, this doesn't look normal here. You could see here there's slight irregularity here. So there's a small aneurysm here. But unfortunately, there's another problem here. You could see here the opacity here, we don't see well. There's clot as well in his posterior cerebral artery, at the top of his basilar artery, and at the beginning of this superior cerebellar artery. So this is someone who bled from an aneurysm that we suspect is mycotic. Because of the infection in his bloodstream from the endocarditis, it eroded the vessel. The vessel become really weak. The wall of the vessel become really weak, and there's a little weaker spot that developed there in the basilar tip, and it bled. Fortunately, it stopped bleeding. Otherwise, the person would have been in the 30–40% of people who would have died right away. Now, as he clot this aneurysm, his body probably react, and he has a clot as well within this artery here. Now, I'm looking at it, and at this point, this is not a good situation. If I go there to remove the clot, obviously this clot is most likely holding where the spot that it bled. So if I go there and remove this clot, probably will make the patient bleed, and the patient will die there. Obviously, this thing does not belong there, and obviously we know he bled for something. But at this point, looking at it, there's really nothing I could do, which is really difficult to accept. It's a young patient, and at this point, sometimes the best thing to do is to stay put. So we decided to wait, hoping that the clot would go away, and then give us the chance to really address the aneurysm. Obviously, not a good idea. We could not really put him on heparin to help the clot go away. So we just put him in the ICU, make sure everything is stable, and again, hope for the best. Fortunately, things are going relatively okay. A few days later, to make sure what's happening with this, we repeat the angiogram. Now, Interestingly, you could see things have changed quite a bit. I told you this is a mycotic aneurysm. The wall of the vessel is quite eroded. So you could see here, this thing is quite fragile. Now, how could I fix that? We talk about coil. If we go ahead and put coils in there, that's not gonna hold. You could see there's no base. If I put balloon there, that's not gonna hold. And the other thing, I'm quite worried because the thickness of this wall, it's probably just like wet paper. It's probably really, really, really fragile. Clipping this aneurysm, it's an area that is extremely high risk of clipping the basilar tip. But in a situation like this, it is quite possible that if I arrive there and try to put a clip, the clip won't hold. It's going to be like trying to clip wet paper, and the thing will just blow and bleed, and unfortunately that's going to be fatal. So at this point, I decide after discussion with some colleague, and we kind of bounced a different idea, and we decided that the safest thing to do at this point was to put him on dual antiplatelets. And the external ventricular drain had been in place for a little while, and we put coils here. I put coils here in the aneurysm, every time taking picture and envisioning that maybe I would see blood spilling everywhere, considering that it is really fragile. And then we put what we call a pipeline, a flow diverter. So I tried to use those two technologies to try to get the best of both worlds, trying to redirect the blood flow and trying to seal what has bled. After this, looking quite decent, still a bit of blood going at the base of the aneurysm there, but quite happy considering what we're starting from and feel quite confident. Hopefully, this patient, dodge a bullet and things will be smooth. Now, decide to repeat imaging. This is the follow-up imaging. On what's happening when people have subarachnoid hemorrhage is that people could develop vasospasm. So the vessel could clamp down. Most of you guys are well aware of this. And sometime in younger patient, it could hit pretty bad. So in November 18, there was clinical changes, and we found that he had terrible vasospasm, pretty much involving all his blood vessel. So with medication and balloon, we reopened those vessels. You could see this is before, this is after. You could see the caliber of the vessel is much better. You could see here it's quite narrow. After that, it's kind of back to a normal caliber. So at that point, while we're treating the vasospasm, we re-image the basilar trunk. And what I thought was looking pretty good initially, you could see this mycotic aneurysm came back with a vengeance. So the part that has coil in it, is pretty much sealed, but there's a lower part that extends toward the superior cerebellar artery that is now quite enlarged. He has spasm. At this point, it's not a good idea to think about doing any other thing for that. Hopefully, after a few days, when the spasm abate, we could see what's happening with this and decide what we're going to do. November 20th, got a call from the nurse telling me that there's pure blood coming out of the EVD. I don't remember the exact number, but I think it was 50 cc's. And you know that there's something bad happening. At that point, his CAT scan had no more blood. The blood has all resolved. And now significant drainage of blood. And you could see now this is the repeat CAT scan. Fortunately, the EVD kind of saved him from high intracranial pressure. But we brought him back to the angio suite, and you could see now, this is not going well. This thing is completely dysplastic. Now this is the superior cerebellar artery. So it's a different vessel that has completely enlarged, and we don't have access to that. You remember when I told you about the pipeline? Obviously, we use the pipeline to try to fix that, but the meshing on the pipeline is tight. So we cannot bring anything there. Otherwise, I could just go and put loops of platinum there and fix that and block that artery. But we don't have access anymore to that area because of the pipeline. So at this point, what other tool do we have? I remember Ricardo, my partner, was in town. I think had left for a meeting, and Ricardo, did the angiogram, and then we were on the phone talking. What could we do? And both of us come to the conclusion that there's not much we could do other than putting another flow diverter hoping that by increasing the meshing, we'll decrease the amount of blood or the speed of blood going to that, and that eventually it's going to heal. But again, we rely on the body for that happening, and we're not going to have an acute treatment of this aneurysm. November 22nd, things again seems like they're going back in the right direction. This is obviously looking much better if we compare to the prior images after 2 pipeline. The posterior cerebral artery, things are looking quite good, and it seems like we're making progress again. November 25, 28, there was another rupture, the one I just showed you. So again, the vasospasm doesn't know that he already had vasospasm. The clock restart, another episode of severe vasospasm with his vertebral artery and his basilar artery being stenotic. Angioplasty was performed at that point to open the caliber of that. December 4th, decide to follow up now that the vasospasm is gone before starting thinking about discharge for rehab. What do we see here? Has progressed. So it's larger than the prior images when there was spasm. So what is the only solution at this point, at least that we could think of, is just let's put another flow diverter, hoping again that we're going to decrease the flow going to this aneurysm. So a third device was placed in, and then he was sent to rehab. On January 11, I hear that he's back to the ER, that he had a seizure. Obviously, we're thinking about the worst. Fortunately, at that point, we get images. We repeat an angiogram, and you could see here, finally, we just see the vessel. There's no more aneurysm, and it seems like things are looking good. And this is the follow-up MRI in August of last year that looked good. Now, what I told you here is really incomplete. Just show you about technique, catheter, show you images. And I have to say that yesterday when I was putting that together, I told Jay earlier, things were bad. I had forgotten how bad they were. And it brings a lot of emotion because we care for people. And through all that, the story would be really incomplete if we don't talk about the vulnerability of the family, of the patient, that suddenly see their life change completely. The vulnerability of us, of the nursing staff, seeing people every day, seeing somebody who's intubated, who, through those roller coaster of emotion, that their life is changed forever, that the plan that they had for their life suddenly is completely disrupted. It would be quite incomplete if we didn't think about all the care. We mentioned about that earlier. And when I say about care, is the nursing care, obviously, imagine all the diaper change that went through all this stay in the hospital. Nobody will ever talk of that. Is it important? Absolutely. If he would have had the ulcer and all that, he would not be here today. All those simple moves that you guys do every day, that a lot of the time, at least I could tell you, I don't take the time to tell you guys thank you for that, but all those things matter. And they matter so much because they make the difference. I'm sorry. And you'll see, seeing Jay, how much it makes a difference. The smile, the tech, the radiology tech that see people, that make us smile, that could touch them, all that make a difference. And it's really, really important. Sometimes, through the hard work, long hour, feeling that, you guys are not valued for what you're doing, I could tell you, you could take the biggest satisfaction in what we're doing, because we're fortunate. What we're doing, a lot of people will look at the computer screen all day long. They won't have access to people. They want to have access to those human interaction who make what we are and who we are. And at the end of the day, we're all craving for those relationships. And we're lucky in our work that we're able to have a lot of time those connections so deep with those people that are in situations of so much vulnerability. And through that as well, I didn't mention all the love. We see that days in and days out, family who are there, that are there days and night, helping those patients by their side, just their presence, just their love, just their smile, just again, those feeling that you look and transcend, sometimes you just wish you would be this person for someone else. And sometimes you see those family, the way they handle things, and you know, I hate to admit, but sometimes I see some people there and I'm like, God, I wish I would, you know, obviously situation bringing the circumstances, but I sure hope I'll be that present for my family and my wife and so on. So this is what's missing. And I'm really proud to have Jay with us today to share what's missing in his perspective and all that.
Good morning. Thank you for having me. If you would have told me on November 7th of 2015 that I would be speaking about subarachnoid hemorrhages today, I would have told you that you were completely crazy. While it may seem astonishing for someone to say they're blessed to be in my situation, I can say I truly am. On November 8th of 2015, my life changed forever. Going back to that day, I remember waking up with a headache, the worst one I ever had. The next thing I remember was waking up about 45 days later and being told I had a ruptured brain aneurysm. I don't remember the ride to the hospital when I was yelling for my mom in the back of the ambulance. I don't remember the dozens of nurses calling my name on November 20th or the chaplain being called in. I don't remember missing my nephew's first birthday on December 5th when I had my last rebleed. After spending 51 days in ICU, I don't remember my ride to Brooks. I was transported on a stretcher to Brooks. I spent the next couple of weeks at Brooks inpatient therapy. I had to learn to walk again. I had to relearn tasks such as holding a spoon. I had issues with my cognitive abilities, such as telling time, simple math problems, recognizing animals. I had to strengthen my muscles to be able to swallow again. It was probably the middle of March before I was able to pass the swallow test. I was not able to shower by myself for the first 3 months at home. I slept in a room with someone because I was a fall hazard should I ever need to get up in the middle of the night. I went to day therapy from the middle of January through May. I was not authorized to drive until August of 2016. Although these are faint memories, some would say that it's best that I don't remember everything. However, there are a lot of things I do remember. I remember the occupational therapist, Miss Catherine, and her not letting me tell her no to every exercise she had me do. I remember my grandma getting me chicken Alfredo and breadsticks from Olive Garden almost every night I stayed in Brooks. I remember the 5 months spent at Brooks brain injury day treatment. And I remember meeting with Dr. Savageau soon after I got out of Brooks and him telling me to turn around one more time because he never thought he was going to see that again. A lot of the things in Brooks, or a lot of the time at Brooks is, it's not, the memory is not all there. But while my memory may not be so well for some of that time at the hospital or at Brooks, I know my mom's is. My mom stayed with me all 51 days and nights at the hospital. While I may not understand the love of a mother, I know that there is no greater love than that of a mother. I know I will never be able to thank her enough for everything she has done for me. I also would like to thank my grandmother for everything she has done, whether it be picking me up every day from Brooks Rehab Day treatment or taking me Mongolian barbecue about 1,000 times. I can't thank her enough. It's hard to think that just 3 years ago, I was at a moment in life where I may not have another moment in life on this earth. As of today, I'm in UF Health's radiology technology program. I have a beautiful girlfriend named Whitney. And have a completely different view on life. When you are 21, you think you have your whole life ahead of you. You don't think that in just a moment all of that could change. Before November 8th of 2015, I can say I took life for granted. I never thought that in a moment, everything could change. Through all of this, I've learned that you are never promised tomorrow. I definitely heard this saying before, but whenever you come so close to that actually being a reality, your whole perspective on life changes. I can say I truly take life as a blessing now. I really would like to thank my mother, nurses, rehab team at Brooks, Dr. Savageau, and Dr. Hannell. And I'd also like to thank God for getting me through everything. Without everyone putting in so much work into helping me recover, I can certainly say that I would not be where I am today. Mm-hmm.